Welcome to the Deep Dive. Today we're embarking on a fascinating exploration into metabolic disorders. These are medical conditions sparked by gene changes that can, well, throw our body's intricate metabolic processes out of sync. Now, it's key to understand we're not talking about developmental disorders, which affect growth and development more broadly. Our focus is sharp. Inherited metabolic disorders and the surprising ways they can manifest right in your mouth and jaw.
Exactly. Think of it like this. Metabolism is the body's central engine, constantly converting fuel into energy and building blocks.
Right.
When there's a genetic hiccup affecting the system, the effects can ripple throughout the body, and sometimes the mouth gives us some of the earliest, most visible clues. We'll be looking at how seemingly unrelated conditions can leave their mark, right there.
Precisely. So get ready as we delve into 6 illustrative metabolic conditions. Paget's disease, hyperparathyroidism, hyperthyroidism, hypothyroidism, hypophosphatasia, and acromegaly.
Quite a list.
Yeah, they might sound complex, but our mission is to pull out the essential insights, the nuggets, really that give a clear picture of how these systemic issues show up orally. Okay, let's unpack the first one. Paget's disease, sometimes called osteitis deformans. What's the core issue here?
Okay, Paget's disease. It's a chronic bone disorder where the normal process of bone remodeling, that cycle of breaking down old bone, building new bone, it just goes haywire.
Goes haywire, how so?
Well, it becomes disorganized and overly active in certain areas. And what's tricky is we don't fully know the exact trigger. Research points to a few things, though, maybe a link to certain viruses like paramyxovirus, environmental factors, and importantly, mutations in a gene called SQSTM1.
SQSTM1.
Yeah, that's found in about half the people with Paget's. Now, these mutations can pop up later in life, but usually they're inherited. This gene, it helps regulate osteoclasts, the bone breakdown cells, so a mutation can make them sort of overactive.
So it's like the bone renewal crew gets a bit too enthusiastic in some spots. Who usually gets this?
It tends to affect folks over 50, mostly. And interestingly, it's more common in men, about a 3-to-2 ratio, and also people of Northern European descent seem to have it more often.
And the jaws. You said they can be involved.
Yep. In about 20% of patients, the jaws are affected. And the upper jaw, the maxilla, gets hit about twice as often as the lower jaw, the mandible.
Okay, so if someone has Paget's affecting their mouth, what might they notice first? What are the signs?
Well, the initial signs can vary. A common one is bone pain, like a deep aching pain in the affected jaw. Sometimes the skin over that bone feels warmer, too.
Warmer. Why is that?
It's because there's increased blood flow hypervascularity in that overactive bone. Then you can get neurological stuff, headaches, hearing or vision problems, even facial paralysis or vertigo if the overgrown bone starts squishing nearby nerves.
Wow. Okay. And in the mouth?
Specifically in the mouth, a big clue is jaw enlargement. It's usually symmetrical on both sides, and often the upper jaw looks bigger. This can suddenly make dentures not fit right.
Ah, the denture fit test.
Exactly. You might also see teeth starting to spread out, getting gaps between them, or even becoming loose. In really severe cases, just closing your lips comfortably can become difficult.
It sounds quite impactful. What about x-rays? If a dentist suspects Paget's, what shows up?
On x-rays, especially later on, the look is quite distinct. You see this patchy pattern. Some areas look really white and dense, radiopaque, mixed with areas that are less dense. It's often described as looking like cotton wool.
Cotton wool. Okay, I can picture that.
Yeah, it signifies that increased disorganized bone formation. You might also see extra cementum buildup on tooth roots. That's hypercementosis. Or the opposite, roots dissolving, which is resorption. And the lamina dura, that thin line of bone around the tooth socket, it might disappear, and the space for the periodontal ligament could get squeezed.
Got it. And blood tests. Anything specific show up there?
Yes, definitely. Usually, calcium and phosphate levels in the blood are normal, but the big marker is alkaline phosphatase, that enzyme involved in bone building. Its level is usually way up, markedly elevated. It reflects all that extra bone turnover.
So how do you manage Paget's? What's the treatment approach?
The main goal is to get those overactive osteoclasts under control. So medications like calcitonin and bisphosphonates are the mainstays. They help slow down bone breakdown.
And there's a rare cancer risk, too.
Yes, it's important to mention. In a small percentage, maybe 1% up to perhaps 15% in some reports, Paget's can transform into osteosarcoma, a type of bone cancer. It's rare, but something to be aware of.
Okay, so for our listeners, the key takeaway on Paget's, a jaw issue, especially enlargement or pain in someone over 50, might signal this wider bone problem. And remember that cotton wool x-ray appearance. Right, let's switch gears. Hyperparathyroidism. What's the story here?
Okay, hyperparathyroidism. This one's all about the parathyroid glands, those little glands in your neck near the thyroid.
Right, the calcium regulators.
Exactly. In primary hyperparathyroidism, they're putting out too much parathyroid hormone, or PTH.
And what usually causes that overproduction?
Most of the time, like 90% of cases, it's a benign tumor on one of the glands, a parathyroid adenoma. Much less often, it's just that the glands themselves are enlarged. That's hyperplasia, or very rarely it could be a cancer, an adenocarcinoma.
Okay, so too much PTH, what does that do in the body?
PTH's main job is to increase calcium levels in the blood. So too much PTH tells the osteoclasts, those bone breakdown cells again, to work overtime. They release calcium and phosphate from the bones into the bloodstream.
So bone breakdown increases and blood calcium goes up.
Precisely. And that high calcium level, plus the bone changes, leads to the classic symptoms.
Ah, yes, the mnemonic.
You got it. Stones, bones, groans, and moans.
Right, stones are kidney stones.
Yep, renal calculi from excess calcium in the urine. Bones, well, that's the bone pathology from all the resorption. Groans refer to gut issues like ulcers or constipation, maybe linked to high calcium.
And moans.
Moans cover the neurological or psychological side, fatigue, confusion, maybe even dementia-like symptoms or depression.
Okay, and how does this show up specifically in the mouth or jaw?
Orally, you might see teeth becoming loose. The jawbone itself, particularly the mandible, can look less dense on x-rays, more osteoporotic, with thinning of the outer cortical bone. And again, that lamina dura around the tooth sockets might partially disappear.
So similar signs to Paget's in some ways, like the lamina dura loss?
Some overlap, yes. But historically, the bone changes here were called osteitis fibrosis cystica, basically. Bone being replaced by fibrous tissue, sometimes forming cyst-like areas on x-rays. Microscopically, these can look just like central giant cell granulomas.
Oh, interesting.
And they have another name, brown tumors.
Brown tumors. Why brown?
Because there's often bleeding within these resorbing bone areas, and the breakdown product of blood, hemosiderin, accumulates, giving them a brownish color on dissection. It's not a true tumor, though, just a reactive lesion.
Got it. So lab tests would show high calcium and high alkaline phosphatase.
Exactly. High serum calcium and often elevated alkaline phosphatase due to the bone turnover.
And the treatment.
For primary hyperparathyroidism, the main treatment is surgery to remove the overactive gland or adenoma. That usually cures it. Sometimes medications like bisphosphonates might be used temporarily, or if surgery isn't an option.
Okay, so the big takeaway here. Things like kidney stones could be linked to jawbone changes. And that brown tumor connection to giant cell granulomas is definitely a key point. All right, let's move to the thyroid. First up, hyperthyroidism. Too much thyroid hormone, right?
Correct. Hyperthyroidism means excess thyroid hormones T3 and T4 floating around. This basically puts your body's metabolism into overdrive. The most common cause is Graves' disease, which is an autoimmune condition.
So metabolism in overdrive. What does that look like symptom-wise?
Think fast. People often feel hot, intolerant to heat. They might have sweaty palms, a fine tremor in their hands, muscle weakness, heart palpitations, maybe even atrial fibrillation.
Wow, the heart's involved too.
Definitely. Also, digestive issues like diarrhea, feeling anxious or irritable, losing weight even if you're eating more. Women might have menstrual changes, hair can thin out, skin texture might change. It's a very systemic thing.
And orally, how does this speeding up affect the mouth?
It's interesting. In kids, you might see baby teeth falling out early and permanent teeth erupting faster than usual.
So development speeds up.
Right. In adults, the main thing we see is more generalized osteoporosis in the jawbones, both the maxilla and mandible, so reduced bone density overall in the jaws.
Makes sense if everything's turning over faster. How's it treated?
Usually with thyroid-suppressing drugs like methimazole or propylthiouracil, they help lower hormone production. Sometimes radioactive iodine therapy or surgery are options too.
Okay, so hyperthyroidism speeds things up, including tooth eruption in kids, and can reduce jawbone density in adults. Now the flip side, hypothyroidism. Too little thyroid hormone.
Exactly. Hypothyroidism is when the thyroid gland is underactive, not making enough hormone. Causes can vary: congenital defects from birth, iodine deficiency historically, but now more often autoimmune causes like Hashimoto's thyroiditis where the body attacks the thyroid. Or it could be a problem higher up with the pituitary or hypothalamus not signaling the thyroid properly.
And you mentioned timing matters here, especially for kids.
Hugely important. Untreated hypothyroidism in infants and young children leads to cretinism, or congenital hypothyroidism now. This causes major delays in physical growth, dental development, and crucially brain development, leading to intellectual disability. That's why newborn screening is so vital.
Right. And in adults, it's called myxedema. What are those signs?
Yes, myxedema in adults. Think slow down. You might see puffiness, edema, especially in the face, lips, tongue.
Yeah.
People often feel mentally sluggish, lethargic. Their skin gets dry, cold, maybe yellowish. Hair loss, brittle nails are common. Pulse slows down, lots of fatigue, maybe anemia, high cholesterol. They often feel cold all the time.
A real system slowdown. And the dental impact.
It mirrors the systemic effect delays. In kids, the main thing is delayed shedding of primary teeth. They hang on to baby teeth longer, and delayed eruption of the permanent teeth. Everything's just slower.
So the opposite of hyperthyroidism's effects on teeth. How's hypothyroidism diagnosed and treated?
Diagnosis involves history, exam, and blood tests for TSH, thyroid-stimulating hormone, and T4. In primary hypothyroidism, the thyroid's the problem, so T4 is low, but TSH is high because the pituitary is yelling at the thyroid to work harder.
Okay.
If the pituitary is the issue, secondary hypothyroidism, both T4 and TSH will be low. Also, a practical point. People with hypothyroidism will clear some drugs, slower opioids, sedatives, blood thinners, so dosages might need adjusting.
Good point. Treatment is hormone replacement.
Yep, standard treatment is replacing the missing hormone, usually with synthetic T4 levothyroxine. Taken daily, it restores normal levels.
Okay, that clarifies the thyroid's role nicely. Let's move to a rarer one. Hypophosphatasia. Sounds like low phosphate something.
Low alkaline phosphatase, actually. It's a rare inherited disorder where you lack sufficient amounts of that enzyme, alkaline phosphatase, or ALP. Remember we said ALP is high in Paget's and often hyperparathyroidism? Here, it's defective and low.
Okay, low ALP. Inherited how?
Usually autosomal recessive, meaning you generally need to inherit a faulty gene from both parents. This faulty gene affects the enzyme crucial for mineralizing bone and, importantly for us, teeth.
And it comes in different flavors, severity-wise.
Yes, several forms. The congenital form is most severe, often fatal for newborns. Early infantile also has high mortality. Then there's a childhood form, where maybe skeletal signs are milder initially, but a key, often first sign is premature loss of front baby teeth.
Losing front baby teeth early, without decay or injury.
Exactly. That's a big red flag for childhood hypophosphatasia. There's also a milder adult form, maybe causing bone pain, fractures, or issues stemming from childhood rickets.
Okay, back to those teeth falling out early. What else happens dentally?
Besides the early loss, primary teeth might have really large pulp chambers. You see alveolar bone loss, especially around the front teeth. But the fundamental problem, a defective cementum, that layer covering the tooth root, it can be underdeveloped hypoplasia or completely missing aplasia.
And without cementum.
The periodontal ligament can't attach properly, so teeth get loose and fall out. You can also see issues with enamel formation, enamel hypoplasia, and enlarged pulp spaces in permanent teeth, too. Premature loss can happen in both sets of teeth. Systemically, it causes poor bone mineralization like rickets in kids or osteomalacia in adults, meaning soft bones prone to fracture.
And lab tests, confirming the name, would show.
Low serum alkaline phosphatase levels, that's the key diagnostic finding.
Right. So the takeaway. Unexplained early loss of baby teeth, especially front ones. Think about hypophosphatasia, this rare issue with cementum formation due to low ALP. Okay, last one. Acromegaly. What defines this?
Acromegaly is all about excess growth hormone, GH. But crucially, it's excess GH after your growth plates have closed, usually in adulthood.
So after you stop growing taller. What if it happens before?
If you get excess GH before the plates close, that causes gigantism, extreme height. Acromegaly is the changes that happen when GH is high in an adult skeleton.
Got it. And what causes this excess GH, usually?
Over 90% of the time, it's a benign tumor in the pituitary gland, an adenoma that just keeps pumping out growth hormone.
So what does this excess GH do to an adult body? What changes occur?
It causes overgrowth of bones and soft tissues. It usually creeps up slowly, often noticed in someone's 30s or 40s. People might notice their hands and feet getting bigger, rings don't fit, shoe size increases, they might sweat more, develop coarser body hair, feel weak, get carpal tunnel syndrome from nerve compression, joint pain.
Seems like a lot of systemic effects.
Oh yeah. Sleep apnea is common, high blood pressure, thicker skin, higher risk of heart disease. Facial features gradually change too. The brow and lower jaw become more prominent, nose widens, lips thicken.
Okay, let's focus on those jaw and mouth changes. What's characteristic?
Very distinctive changes. Both jaws, mandible, and maxilla tend to enlarge. As the bone supporting the teeth grows, you get spaces opening up between the teeth. The mandibular condyles, the jaw joints, can overgrow condylar hyperplasia, leading to that classic protruding lower jaw, prognathism.
So an underbite develops or gets worse.
Exactly. The angle at the back of the jaw, the gonial angle, often increases. A posterior crossbite, where the upper back teeth bite inside the lowers, is also really common. Plus, the tongue can enlarge, macroglossia, oral tissues thicken, lips get fuller.
So if an adult notices their bite changing, their jaw seeming bigger,
Yeah,
that could be a sign.
absolutely. Gradual changes in facial structure and bite in adulthood should definitely prompt consideration of acromegaly. It's quite striking that the jaws can keep growing after skeletal maturity.
How's it diagnosed and treated then?
Diagnosis involves blood tests for GH and related factors, plus imaging like an MRI to look for that pituitary tumor. The main treatment goal is to get GH levels back to normal. Often the first step is surgery to remove the pituitary adenoma.
And if surgery isn't enough,
Then medications can be used to lower GH levels or block its effects. And because the bite changes can be significant, corrective jaw surgery, like moving the lower jaw back, might be needed later to fix the malocclusion.
wow. Well, this has been an incredibly insightful journey looking at how these different metabolic gears slipping can show up right in the mouth. We've covered Paget's bone chaos, the parathyroid's calcium control issues, the thyroid's tempo setting, hypophosphatasia's enzyme lack, and acromegaly's growth overdrive.
Yes, and the big message, I think, is just how linked everything is. What seems like just a dental issue, loose teeth, jaw pain, changing bite, could actually be the body waving a flag about a deeper systemic metabolic problem.
It really drives home that the mouth isn't separate from the rest of the body. It highlights the value of dentists and doctors talking to each other.
Yeah.
Seeing the whole picture.
Definitely. And maybe a final thought for everyone listening. How many things we consider just normal variation in teeth or jaws or changes as we age might actually have subtle metabolic roots we just don't fully grasp yet?
That's provocative. Like the mouth really is a window.
It could be. Offering clues to our overall health if we just keep looking, stay curious about those connections.